The first one, you can see it's a case of insect bite. The child had not a bite, to be precise, insect sting. The first photo. I hope the photo is clear, visible. You can see the vesicle and bullous lesion together. That's why I have put that. The first small lesion is a vesicle and the next lesion is bullous. Can you please tell what is the second photo about? The skin is much thickened. Both the palm and foot of the same child, same case, you can see the lichenified lesion here. Skin is thickened, hypertrophied, and in the third case, you can see a case of eczema, where there is exfoliation with the hyperpigmentation and a little bit of oozing in it. You can see cracks also. Fourth photo is of pemphigus vulgaris, where you can see pustular lesion and also the skin is totally infected. You can see the hemorrhagic spot because of bleeding on the lip as well as on the cheeks and pustular lesions. Next photo is papular lesions. Papular lesions, second row, first photo. Papular lesions. Second photo is a very rare clinical condition that comes to our practice. It's a case of giant cell tumor. It's a case of giant cell tumor. It's a benign tumor, but takes a lot of effort for clearing it out. It took nearly 6 months to bring that leg into normalcy. We will discuss, while discussing about the yogas, I hope I will be getting a third session to discuss about yogas, which are helpful in managing the skin lesions, the skin disorders. This is a case of giant cell tumor. It's a feature for ulceration, And the fourth one, if you see, it's a case of beginning of a cellulitis, where the patient also has inguinal lymphedema. The patient had fever. You can see the lesion slowly turning out into red, discrete patches all over with oozing. Next, another variant of exfoliative dermatitis. Next one is a footwear dermatitis, last photo, where you can see the pattern of footwear, that imprint has come. It's a case of irritant contact dermatitis, where there is vesicles and also pustule together with oozing. This is another case of, can anybody tell what is the first photograph? Participants, please. The first one, is it a fungal infection? Can we consider
Urticaria?
urticaria? No. What is the lesion? Can anybody tell what is the lesion according to the discussion? It's not a case of herpes. It is erythematous.
Patch.
It's erythematous.
Eczema.
I will tell an interesting story about this. We tried in the line of fungal infection because the lesion was active. In every case of fungal infection, the lesion will be active in the periphery and there will be a clear margin inside. As the skin goes on healing, a fungal infection has a characteristic clearing in the center and the infection getting spread in the periphery. But we were totally misled, and it was a case of allergy due to the bite of leech. It was a bite of leech had bitten, and that had caused a very similar lesion. If you see the lesion very thoroughly, you can see small papular lesions together and also hyperemic or erythematous, discrete, and we can even demarcate the borders. It happened to be a leech, right? But it took 1 or 2 visits for us to get the history properly. We tried with fungal management, but we were totally failure in it. Then we came to know it was a leech bite, and when he revealed the history, we managed in the lines of Savisha Jalauka Damsha, and we got the result. See how next photo. Can anybody please tell what this lesion is? Second photo, a classical site, a very classical site of eczema because of varicose, and it's called, it's wheel and vesicle, okay, and it is called stasis eczema. It's a case of stasis eczema. Before discussing, all these cases are dealt in our later half of discussion, so please don't worry. It's a case of, I just need our dear participants to get accustomed to the photographs first, so that we can, when we explain, you can remember these cases. See, you can see even dribbling marks of that oozing on his skin. So it's a case of stasis eczema. You can see all the markings, and it's a secondary lesion. And what is the next lesion? Third photograph. You can see exfoliation in it. Please. Yes, please.
Sir, tinea, sir, tinea infection.
It's a tinea infection itself. It's a tinea infection itself. But you can see 2 aspects of lesion in this boy. One is exfoliation, which is very gross all over the body. And if you see his posterior aspect or extensor aspect of elbow, there is another lesion. There is another lesion. That is thickened, lichenified lesion. So both are same. It was managed in the lines of tinea corporis, and he was managed. Ulcer, not only ulcer. If you see the next photo, fourth one, the ulceration is associated with the black, foot is totally dark, and there is occlusion of peripheral circulation. Occlusion of peripheral circulation. She was a case of RA and later on developed ulcer. Once the patient got all these complications, she came to our IP and she was admitted and she was managed. It's a case of rheumatoid arthritis with the ulcerations, multiple ulceration. Actually, she had maggots also on her foot. Next, fifth one, you can see the trackings of the lesion. Fifth photo, fifth one, black on the palm, keratotic lesion, thickened with the cracks. This is, can anybody please tell what this lesion is? Fifth photo.
Lichenification.
Of course, definitely. Correct. It's a lichenified lesion. And what about the next one? It's a leg. Sixth photo.
Cellulitis.
Nodule.
No. No.
Pustules.
Pustules, definitely. It's a bullous eruption. We call it a bullous eruption, which is seen all over the lesion. There is no pattern in it. There is no pattern in it. It's a bullous eruption. It's a bacterial infection. That is why it is in that form. You can see crust formation also once that bullous has burst out. If you see the lower aspect of the photographs, you can see dark areas, right? You can see dark areas, and they are all crust formation. And the biggest pustular area, bullous area, if you see one lesion over that which is red in color, it's a blood-filled lesion. Blood-filled lesion. And can anybody tell what is that blood-filled lesion we discussed?
Hematome.
Hematoma is a bigger lesion. One question has come. I will answer that also. In the fourth picture, how can we differentiate it to diabetic foot? Of course, first of all, we have to ask whether the patient is diabetic, and there should be a history of uncontrolled diabetes and a lot of negligence from the side of the patient. And if the patient is diabetic, which is uncontrolled and negligence part, and the ulcer was the only pathology, we can consider it as diabetic foot. I have a photograph of diabetic foot also. We will see that. In the next coming photo, we have a diabetic foot. If we see this case, fourth photo now, and once we compare it with the upcoming next photo, we can differentiate. And next two photographs are footwear dermatitis itself. They are of different extent. That's all. The first photo was of a small girl who had recurrent infections in spite of changing her footwear. You can see the thickened lichenified areas as well as the active lesion. That's why I took the photo. But in the last photo, it is just a common chappal allergy where you can see ulcerations also. Okay, I won't talk a single word about Ayurveda also. If you see in Sushruta, Kalpasthana first chapter, in Sushruta Kalpasthana first chapter, we can see Paduka Vishalakshana. Out of that, a classical Paduka Vishalakshana explanation is this photograph. If the recording is available, if you please remind me in the later part of our presentation, on the third presentation, I can explain the treatment also. This is a case of classical case of Sushruta Kalpasthana, first chapter, Paduka Vishalakshana. Next slide. We will go. This is another remarkable case. The lesion is all over the body, widespread, vesicular, erythematous, hyperemic, oozing, pustular, multiple lesions are seen. It's a case of erythrodermal psoriasis. It's a diagnosed case from medical college, erythrodermal psoriasis. But we treated this guy in the lines of Grahani and we got result that is different. Now this lesion is very characteristic. On the second photo, you can see another variety of stasis eczema. If the first photo of that blue chappal guy, we saw one oozing lesion where that dribbling of oozing was seen. This is another variant. It's on the outer surface and you can see a lot of ulcerations and also lichenified area, and the lesion is little bit Vata-Rakta sort of lesion. What about next? Next one is this is blood-filled lesion, the third one.
Lichen planus? Is it lichen planus?
It's not lichen planus, madam. It is actually blood-filled actually. It's blood-filled and it's a bullous lesion. It's again bullous. A larger one, which is more than 2 centimeter, 2 millimeter in, 2 centimeter in diameter, much more bigger, blood-filled.
Okay.
Okay. Now this one, first and second photographs, a case of atopic dermatitis, where the lesion is all over the body. It's a patch, white, pinkish in color, and a classical presentation or a textual presentation of this lesion is seen in this child. Now the next is that trunk. Two photos are of similar diagnosis. One is unconfirmed. The patient is telling one history, but it's a case of herpes. And below, it's a case of spider envenomation. First case is telling about spider envenomation. But actually, it's not a case of spider. The patient is totally misdiagnosed or misled by some other factor. I don't know. But this is a case of herpes zoster. There is a dermatome presentation with severe pain, and we can see multiple lesions in that. And just below, there is the blue and yellow shirt boy. And this is a confirmed case of spider bite, where herpes and spider envenomation can be differentiated in the feature of excruciating pain. The man had severe pain on the lesion with fever, but this boy had all the features except pain. You can see multiple lesions. There is a red spot, yellow spot, white spot, and black spot. It's all vesicular and pustular lesion and crust formation are there in a single photo. Plantar keratosis. It's not a case of psoriasis. Plantar keratosis. Dry furrow. Burrow is there. Big canal-like. And next is the photograph of a boy with can anybody please tell the lesion?
Urticaria.
Urticaria.
Yes, sir. Yes, wheel is the name. Urticaria is diagnosis. Wheel is the name of the lesion. Urticaria is the diagnosis. But surprisingly, this urticaria we managed in the line of Chardi Nigraha Jagadaha, Charaka Sutrasthana. He had a history of Chardi Nigrahana by taking Avamine syrup. Then he developed this one overnight. Next one, first photograph is a case of hidradenitis suppurativa. Both the lesion, first and second. First photo and second photo is of hidradenitis suppurativa. You can see sinus formation. Sinus formation. All the ulcerations are internally connected. Inside, they are all having tunnels which are interconnected. It's a case of hidradenitis suppurativa and a TB positive case. He was diagnosed as Cox positive and he was treated with AKT. Together with that, we treated hidradenitis suppurativa. And what about the third photo? A swollen face. It's also a case of hypersensitivity reaction. Wheals are there. And it's a case of semicarpus anacardium. Ballataka toxicity. Ballataka toxicity. You can see the features of type 1 hypersensitivity. What about next? This is a classical presentation of morphia. The photos 4th and 5th. It's a case of morphia. Now, next, that palm, it's intertrigo. We all will discuss about all these cases. Intertrigo. It's in between the fingers. It's a fungal lesion. You can see reddish exfoliating lesion. Exfoliating lesion. Now, what about this? I think everybody can answer this. First 3 photographs.
Psoriasis.
Of course. And type of lesion?
Bullous.
Not bullous. We can differentiate excoriation and exfoliation in the factor that exfoliation will have shedding of skin. Excoriation will not have shedding of skin, but there will be dryness and the scar formed due to itching, which is permanent. There was a question in the chat box. This is a case of psoriasis, of course, but I am expecting one more finding in the photograph, first photograph, one more finding.
Sir, tortuous of vessels.
Means
Yes, absolutely correct. This is something bigger than skin lesion. This is where we get confused. When he lifted the shirt, we first noted the psoriasis, and when we saw those engorged vein with the right hypochondriac swelling, I hope that gross swelling on the right hypochondriac region is visible with a small color change also. He is a case of an autoimmune disease. Skin was only a symptom. If and only if we had tried with psoriatic management, we would have failed. It's a case of Budd-Chiari syndrome. Budd-Chiari syndrome. He came to our OP and we treated him for near about 2 months, and he was totally relieved from the symptoms. He had hepatomegaly, and that engorged vein is due to ascites. He had splenomegaly also. By further investigations, we got all the pictures, and he went to medical college, got the diagnosis, came to our hospital, and he got treatment for 2 months. And we treated him in the line of Vishachikitsa, and we got a very encouraging result. But as far as the lesion is concerned, it's a case of psoriasis. Can anybody tell what sort of psoriasis is that? Whether it is plaque, whether it is psoriatic arthropathy? No, we will discuss. We will discuss in the next coming one. And all the photographs are of psoriasis itself. All the 7 photos are of psoriasis itself. But one is an autoimmune disease related condition where psoriasis is only a feature. For the second next group, that palm and foot, is of pustular psoriasis. Pustular psoriasis, which seems to be the presentation of an eczema. It is not an eczema. It's a case of pustular psoriasis. And in the third case, it is a case of plaque psoriasis. And all these three are different presentations of a single disease. You can see the case of cellulitis. In a case of no, I won't tell. Please, the first 2 photos. Yes, of course. Varicose vein is there. In that photo, we can see varicose vein of that 2 lady. It's a case of varicose ulcer with cellulitis, and she had an occlusion pathology on venous drainage. It was a case of vein thrombosis, and we had treated in her in OP level management by Vata Rakta Chikitsa. And what about the next 3 photographs?
So seborrheic dermatitis.
There is seborrheic feature, of course. As far as the lesion is concerned, I had put what you have told is very, very correct. It's the presentation is seborrheic, but her eyes mentions everything. Please note her eyes.
Jaundice.
It's a very rare clinical condition. It's a very rare clinical condition called xeroderma pigmentosa. Xeroderma pigmentosa, a benign condition, but the survival rate is nil, 0 survival rate. During the adolescence, there are all the chances of death of the person, death of the patient. It's a case of xeroderma, 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 xeroderma pigmentosa. But seborrhea, absolutely correct. The feature is very much like seborrheic dermatitis. Next photograph. See, a big fungal lesion. It can come in this way also. On the flexures, 2 huge lesions. It's a case of fungal lesion. And if you see, very clear-cut margins are there in it. If the margins were not clear-cut, we should have suspected some autoimmune disease in this boy. But to our clarity, the lesion is very much demarcated from the normal skin, and there is clearance in the central area. And the next two lower limbs, the photograph in the middle, are put deliberately because the first photo, that dhoti blue chappal fellow, can you see that blue chappal? Second photo. And this lesion is psoriasis, psoriatic lesion. It was a case of psoriatic arthropathy. But I showed this photo because we got relief by our medicine from psoriasis. Once psoriasis was cleared, you can see small pustular lesions in the leg. It is folliculitis. So, what is the reason behind putting the two lesions in the same person after getting relieved from one clinical condition? He had an underlying pathology of folliculitis, superficial folliculitis. Folliculitis is inflammation of follicles, pustular lesions on the hair follicles. And then we had to treat that folliculitis later. Then we came to know that he had this lesion, and this was treated by some other medicine, which resulted in the flaring up of psoriatic lesion. I hope I was clear in the mentioning the series of happenings in that person. He had psoriasis. Our medication was tried. He got significant relief by from this skin lesion. Then once that lesion was cleared, we saw folliculitis in him. And that dhoti boy with that brown colored dhoti boy, it's a case of road traffic accident. He had multiple fractures of lower end of fibula and tibia. He got operated, and this is a failure of skin graft, where you can see ulceration, the dark necrotic areas. That skin area had to be removed. We did total debridement of the skin, and then we tried with our medication, and he got very good relief. So that is clinical aspect. For our diagnostic area, this is a case of failed skin graft, where you can see necrosed tissue around that ulcered area. And the last papad-like leg piece of plaque psoriasis. This is seborrheic dermatitis. Seborrheic dermatitis, but the reason is different. The reason is spider. She had crushed a spider at night during the sleep, and after 2 days, this much worsening of condition was there. See how problematic the secretion of spider can be. This is clearly a case of seborrheic dermatitis. The presentation is this one, but it is only a symptom, but the cause is spider. And next one is also the cause is spider. This fellow had also crushed a spider on his face, and he told the color of spider also, it was green, small. And he had done at home, you can see one area of skin got necrosed, gangrene seen, a pus periphery is seen, and this characteristic feature is called eschar formation or eschar formation. ESCHAR. ESCHAR. This eschar formation is very characteristic and it's very rare. So for your information, I had put this. Am I audible? Am I audible?
Yes, sir.
Okay, shall we continue? Presentation, rare condition of eschar formation, where we can remove this thing as a papad, just like a full black lesion can be removed. If it is removed like a tawa se dosa jaise nikalte, we can remove this, but removal should be very careful. So what we did was, we had allowed that lesion to get dried. We had started our management and we had allowed it to dry, and it had fallen by itself. A very hard papad-like material. So this is eschar formation. You can remember it, this lesion. And this one, the third photo is also very unique. This is a bite of a human being. This is because of bite of human being. This girl's younger sister had bitten. See how a human being can also be venomous. Bite of a human being. She had a history, and you can see the bite marking on the periphery. See, on the lower end, you can see bite marking, clear-cut bite marking. It took 4 or 5 days to manifest these features, and this can also happen. And the lesions are very characteristic. You can see a pustule, a very big lesion, and no infection, no other inflammatory features are seen. She had itching and oozing from that lesion. That's all, nothing else. This is a case of ulcer again. We had treated in our IP for nearly 2 months. It's a case of ulcer due to adverse drug reaction. Some ointment had been applied to this guy from another hospital due to the snake bite. He had a snake bite. He got management for snake bite from another hospital. He was applied with some ointment. Unfortunately, we didn't get that discharge summary because he straight away ran from that hospital without informing to the hospital people. So we could not get the discharge summary. So no detail of that ointment is there, but this was the resultant. So with this hand, he came to our IP. So you can see all the tendons exposed. You can see the tendon is totally lost on the little finger. You can see the necrosed area on the little finger, and you can see the healing tissue, healthy tissue on the second photo. And on the third photo, you can see the scar formation on the periphery. I had put this photo because you can see all the lesions together. Necrosed tissue is there. You can see the tendons. You can see the healing tissue. You can see that finger. We could save all those fingers. Nothing had happened. And you can see the scar in the third photo. On the lower aspect, you can see a small white area. That is clearly a scar formation. On the second photo, you can see the scar formation on the healing area. Now later, this will turn to a keloid. Keloid, which we should never poke. So these 6 or 7 lesions are there in a single photograph. These are maggots. Ulceration with maggots. Now, first thing that we have to do is identify the maggots and then manage accordingly. You can see sinus. For explaining sinus, I had put this photo. You can see a clear-cut demarcation on a single ulcer, and on the right superior lateral aspect of this photo, you can see 3 holes. That is a sinus. And second and third photo is of psoriatic presentation, psoriasis, but the lesion is patch. It's not lichenified, it's not hardened, it's not scaling, but it's a case of psoriasis. Another rare presentation of psoriasis. This is again different patterns in psoriasis. We have already explained enough regarding psoriasis. Keebner's phenomenon is very evident in this. On the second photo, the striae, the lines, the linear pattern of the lesion is the diagnostic Keebner's phenomenon in the case of plaques, hyperkeratotic lesion on the palm and foot, exfoliative lesions on the palm. See, yes. And the next, that boy. Can anybody please tell what this lesion is? It's on the neck also. It's all around the lip.
Herpes simplex.
No.
Herpes.
No.
Seborrheic dermatitis.
No. The site of lesion is very characteristic. Pardon? Once more, please.
Impetigo.
Impetigo.
Perfect diagnosis. It's impetigo. This is the pustular lesion, bacterial infection, streptococcal or staphylococcal. So we have to manage it because it is contagious. Is it boring? Should I change the way of discussion?
No, sir.
No, sir, same.
No, sir. That's things.
We will continue in the same manner. This is again another lesion. See, a linear pattern is seen with ulceration, thickening, and oozing with severe itching.
Lichen planus.
Yes. LSC, simplex chronicus. And there was a small doubt regarding its diagnosis. He was sent for patch test because we were suspecting an autoimmune disease. This boy had simplex chronicus, but in the biopsy it came out to be a LSC, but he had raised ASO up to 1600. ASO, the normal range is 200, but for this boy it was 1600. We managed him in that line, but the lesion is very characteristic. It's in a linear pattern. This one, erythrodermal psoriasis. You can see erythroderma, erythema is there, redness is there. The lesions are all over the body and the skin is getting peeled off. It's called erythrodermal psoriasis. Usually there will be a classical odor, a smell will be there in the patient once we go there. This may not be seen in the textbook, but in the case of erythrodermal psoriasis, we can feel a sort of different smell from the body. That is very significant. If that smell is coming, we better go towards investigating his albumin levels, protein albumin, because if at all there is any depletion in albumin, the patient will go for hypoproteinemia and there can be complications. So better to manage that one also while managing with this erythrodermal psoriasis. Now comes, I hope you remember that small boy